For our next speaker, Dr. Christopher Foglia is Chief of Colorectal Surgery at NYP Queens. He will be talking about colorectal cancer surgery, open versus lap versus robotic. And we can see your slides.
All right, terrific. Okay, thanks everyone. Thanks, Dr. Ficara. So I do not have any financial disclosures. I do, however, disclose that the majority of the operations that I do are performed using minimally invasive techniques, either laparoscopic or hand-assisted or robotic surgery. So I have a little bit of a bias. So we'll jump right in. You know, open surgery is traditionally, as you see in the picture, big incision, good exposure, but more morbid for the patient. Laparoscopic surgery, we use small incisions, put a camera inside. We have small instruments that go through these incisions that we stand at the bedside, hold on to, and manipulate the tissue. Robotic surgery, we do the same thing as laparoscopic, but the robot holds on to some specialized instruments. We go over to a console and we stick our head in the console, see the images, and we can work from there. So which one's the best? Well, they all have their advantages and disadvantages. Open surgery, we get excellent exposure. We have tactile feedback. We can use our hands. The instruments that we have are extensive. Laparoscopy, we have, less pain, improved visualization, shorter length of stay, probably less cost when you factor in the length of stay, quicker return to work, and overall just fewer complications. So the pros of robotic surgery, as I mentioned, there's these different instruments that are wristed. You can see the diagram. I'll show you a picture in a minute. And better visualization, stable platform. The camera is held by the robot, not by a medical student. But there are some cons. It's more expensive. Operative times are longer. You don't have tactile feedback, which most of us have gotten used to. The newer robots do have some tactile feedback. And the surgeon's not at the bedside. If there's ever a major thing that happens, we have to quickly scrub and get back to the bedside. So just a kind of a demonstration of the wristed instruments. This is kind of how straight sticks work. And then just moving the instruments around, you can have a lot more mobility and reach a lot of places you otherwise may not reach. So just going back a little bit historically, laparoscopic cholecystectomy first started back in the 80s. And by the mid-90s, it became standard of care. And it was kind of obvious. You went from incision that looked like that to something that looked like this. Big trauma on the outside. You figure this is going to translate into better outcomes for the patient. But even back then, there was some controversy. Should we be doing this? Well, I can do it better with a mini lap incision, or is this really what we're going to be doing? But it quickly became the standard. For colon surgery, there's different technical challenges than there are for gallbladder surgery. We've got to have specialized instruments so we don't injure the bowel. We thinking about anastomoses instead of just resections. We got to make an incision to take the specimen out. There's a high steep learning curve involved, and then there's cancer-specific concerns. Are we going to expose the tumors to air? Was kind of the wise tale, and it's going to make things worse. Earlier reports had port site recurrences that we were worried about. And are we going to be able to do better cancer surgery, or is it going to be worse? So we started looking at this back in the 90s. We did canine models, cadaver models. We were using new devices. We were comparing and concerning about it. And a lot of this work and all these things that I just showed were done by this guy, Dr. Milsom. I picked an old picture of Dr. Milsom because this was back in 1998 when he first published something in the Journal of American College of Surgeons. Back then he was in Cleveland and looked at 109 patients that were randomized to either laparoscopic or conventional surgery to see what the advantage might be. And as predicted, there was advantages in things like recovery of pulmonary function, less pain, quicker return of bowel function, and in this early colon cancer study, similar oncologic adequacy, just measured by tumor margins being clear. In a 1.5-year follow-up, didn't see any port site recurrences, and that turned out to be something that really wasn't an issue. So they said that these techniques are safe, fast recovery, and there's no short-term oncologic disadvantages. So we said, all right, well, let's look at this, not just doing it with the first 100 patients that we get, but let's look at it with more patients, longer term, and we've got some big studies that came from that. The COST trial was one of the first ones published in the New England Journal in 2004 and follow-up in 2007 in Annals. 870 patients that were randomized between laparoscopic and open colectomy, and they saw no significant difference in their oncologic outcomes with disease-free survival, overall survival, and recurrence rates, suggesting that there was actual oncologic safety in doing these operations laparoscopically. Color trial followed that, where they had a similar randomization, over 1,000 patients, 10-year follow-ups, no significant difference in the long-term survival and recurrence. Classic trial was the next one, where we looked at conventional versus laparoscopic surgery, and again, same thing, no significant difference. Now, in the classic trial, however, they did include some rectal cancer, and they found that there was a higher positivity of the circumferential resection margin after their laparoscopic anterior resections, but this didn't translate into any difference in local recurrence. But we said, we're not sure about rectal cancer. So what about laparoscopic colon cancer surgery? Should we do it? Yes, we should. So you're going to see a theme here with the Ted Lassos. So then this guy here, Dr. Ficara, in fairness, this was in 2020, so I'll use a more updated picture. He wrote a review article back in 2020, and he said the absolute benefits of laparoscopic resection for rectal cancer are still under evaluation. Its safety in terms of early prospective clinical trials has been confirmed. 2 recent randomized control trials have questioned its routine use in even expert hands, since its non-inferiority has not been demonstrated. Furthermore, the impact of robotic technology is still unclear, since the only randomized controlled trial failed to demonstrate any benefit. So, what's the difference between rectal? Well, this is where colorectal surgeons really kind of earn their keep. There's a lot of overlap with general surgery, but really we concentrate on this last 10 centimeters, and that's what takes our extra training. And what happens down there is the peritoneal reflection. Things down there are hiding from view from above, and they're more difficult to reach from below. Lots of different things that make it difficult to operate in this area. We've got the narrow bony pelvis, worse in the man. Challenges with obese patients. We've got lots of different organs and structures down there that in this tight space that are difficult to identify. Low tumors that we worry about the margins and doing proper surgery. And then we think about balancing oncologic outcomes and taking out the cancer with preservation of function, avoiding stomas, and trying to give people good lifestyles. And the surgery is important. Radiation helps us a little bit by sterilizing the field to some degree, but we have to do good surgery with proper anatomic planes and a proper anatomic dissection to perform a good lymphadenectomy and decrease the risk of local recurrence. So with open surgery, we did this through big incisions. We had our hands down there. We could feel the tumors. We could peel things back, dissecting right on the sacrum. I've got a set of these big giant retractors that I hardly ever use anymore. We had these big operations through maximally invasive surgery. Let's see. You see immediately when you just with minimally invasive, and this is a robotic picture, you're looking way down there from above, but you can zoom all the way in, looking down and say, well, we can't really see, above this area. We'll flip the camera over 30-degree scope, and now we can see kind of the rectovaginal septum there. So it's immediately apparent that, there is some advantage certainly in what we can see and how we can reach these areas. So just like laparoscopic cholecystectomy quickly evolved, was this going to happen too? Are we going to replace open surgery with minimally invasive surgery for colon and rectal cancers? Well, like I said, going back to what Dr. Ficara said in his review, the 2 randomized control studies that were early on questioned the routine use because it did not demonstrate non-inferiority. So what were these? These were the ACOSOG trial Z6051 and the a la carte. So in the ACOSOG, it was first put out in JAM in 2015 with a long-term follow-up in the Annals in 2019. They looked at, and this was data that was collected, 2008 to 2013, 486 patients in US and Canada, rectal cancers, looking at primary endpoints of margins, essentially. And what it showed was all the endpoints individually were okay. There was comparable negative circumferential resection margins, comparable distal margins, comparable complete or nearly complete TMEs. But if you looked at these things in aggregate, there was actually a decreased margin, or a worsened margin positivity and worse resections in the laparoscopic cases. So just minimize this, sorry. So 82% versus 87%. So this failed to meet the criteria for non-inferiority for the pathologic outcomes. All the other things were there, the benefits of laparoscopic surgery, but the oncology was what we were worried about. Well, following that up in the longer term, this didn't really translate into any difference in disease-free survival or local recurrence. So we said, all right, well, we may be getting not as good margins. Maybe the radiation is helping us a little bit. Maybe the chemotherapy is helping us because it's not translating out into negative outcomes. Similarly, the a la carte trial in New Zealand and Australia, 475 patients, early 2000s, rectal cancers, and they found the same thing. So repeated the same thing, 82% in laparoscopic versus 89%, very similar numbers, looking at the composite score of whether or not you had a complete resection. So, okay, so, and again, in that also, the overall recurrence did not bear out to show any negativity in the laparoscopy. So they concluded that while laparoscopic rectal cancer surgery may have some maybe non-inferior in terms of its resection margins, this doesn't necessarily translate into a negativity in overall and disease-free survival, but you might be less likely to achieve an optimal pathologic resection. So, well, you say, well, wait a minute. So robot, we're going to be better with the robot, right? Because we can get down there easier. We can use those fancy instruments and really get things taken out. But let's see. Well, the ROLAR trial, that was the next thing we said. Well, we're going to do better with the robot. So the ROLAR trial was published in JAMA in 2017 and took 471 patients that were randomized to either robotic or laparoscopic surgery. Looked at the primary endpoint of conversion to open surgery. And there was a trend towards improvement in robotic surgery, but it wasn't statistically significant. And the secondary outcomes, lap versus robotic, they were all pretty much the same, except for the operative times, which were longer in robotic. And they did a crude cost analysis in the study that said the cost was going to be less in laparoscopic. Just makes sense. So if we're going to do it, why don't we just do it laparoscopically and not robotically is the point. So it didn't really offer any significant benefit over laparoscopy for rectal cancer resection. So what did we say? We said, well, yeah, let's just do it anyway. It just makes sense. The robotic stuff, we can get down there, we can do all these things, and it's going to be better. And that's what we did. The numbers from robotic surgery have continued to rise. The numbers for open surgery have continued to go down. And in 2014, the number of laparoscopic rectal cancer resections passed those for open. And in 2018, the robotic passed that for open as the open continues to decline. And we're creeping up on lap equaling robot. So why do robotic surgery for rectal cancer? Well, why are we doing it? Because we believe that it's going to work. We just kind of had this same feeling that we had with gallbladders way back in the day that it's going to be better. And it probably is. We're starting to see now more data coming out on rectal cancer and robotic surgery, and it may be showing some signs that it is better. This was just published back in June of this year in JAMA. Out of China, 11 centers in China, randomized controlled trial of 1,200 patients with middle to low rectal cancers who were operated on between 2016 and 2020. And the robotic group actually did better than the laparoscopic group. Their main outcome that they were looking at was the local recurrence rate, which was better in robotics, 1.6% versus 4%. But they also saw a slight improvement in disease-free survival in the 3-year time period. Also a little bit better in urinary function, sexual function, and bowel movements after surgery. And this kind of translates this translates from how well we can see everything down in the pelvis. Can we see those nerves? Can we do a good distal transection and have just a better surgery overall? They didn't really see any difference in the overall survival, but all these things were starting to add up. And since that time, there's been lots more. These are all just some studies from 2025 coming from different places, from Japan, from the Netherlands, and we're seeing more and more surgery being done for robotics, and the data is finally catching up that says that it's working out. So good for me, because that's what I've been doing for the past 10 years when I did my first robotic rectal cancer surgery. And so we think that this is probably the way to go. And let's see if I can play these both at once. Yeah. So in summary, colon cancer, laparoscopic surgery versus robotic surgery, they're probably better than open surgery. And we've seen the data to show that. The earlier, COST and classic and color trials showed us that the minimally invasive stuff is probably going to be better than open. Is there still a role for open surgery? Yeah, there certainly is in difficult cases or complex cases or locally advanced tumors that are invading into other organs. Sometimes you can't do these things very easily laparoscopically, and it requires an open operation. They have comparable oncologic outcomes, but the cost is still a thing for robotics. So rectal cancer, what about rectal cancer? Again, it didn't show things that were advantageous at first to use the robotics, to use laparoscopy. We were concerned about cancer outcomes. As we studied it more, just kind of believing that things were going to turn out to be better with these better visualization, better techniques, being able to get down there. It's really hard to get way down there in a deep male pelvis that's in an obese man. And the robot just makes it a lot easier. And the latest studies show that there's probably some improvement even in the oncologic outcomes. Oh, I lost my last slide, but that's it. So the last slide that I somehow lost was, what about robotics in colon cancer surgery? And that's something that I personally am starting to do a little bit more. I know my partners do it pretty much all the time for their right colectomies, and I'm doing it more and more for my right colons, where just sewing intracorporeally is easier for me, and there may be some advantage there with decreased extraction site size or infection rates. So that's kind of the up and coming thing. The cost is still there, but we are getting better and better, and the Da Vinci company is getting richer and richer. And that's it for me. Thanks.
Great. Thank you very much, Dr. Foglia. I see no questions in the Q&A. Any questions from the other panelists? I really enjoy the historical journey that you took us through, and especially some historical pictures of some of us with either dark hair or hair period, and important studies from the past. What seems to be a recurrent theme that we heard also in previous talks is the fact we design a clinical trial based on an important question. It takes a few years to get an answer. In cancer, several years. We get the answer, we don't like the answer, and we keep doing what we were doing before, or even more so. And then I find that interesting. I think some of the study designs of these trials were okay for the time the trial was designed, but not as we progressed. This composite score that the ECOSOC trial used, I found it to be cumbersome at best, but also created all sorts of confusion, at least in my opinion. Clearly, as you said, the robot is here to stay, and for rectal cancer, there is definitely an advantage, as you said, in visualization, and also something you didn't mention is the fact that prolongs longevity for surgeons. As I'm getting up there in age, it hurts to do an open, pelvic demolition, and I'm sure for Dr. Jafari, those long high pack are becoming more and more taxing, and the robot helps quite a bit. How would you tell somebody? We have some trainees on the webinar. How would you describe your journey to proficiency in robotic surgery? Granted, now the new generation is getting trained during residency and fellowship, but how do you summarize your journey to
Yeah,
robotic proficiency?
it's interesting because when I was applying to fellowship, the big thing was laparoscopic colons, and you were looking for a place that was going to do lap colons, and the hot spots were Leahy and WashU, and those were like the places I didn't get in there, but those are the places that were 1 and 2 on my list of where I wanted to go to learn that. Now, so I learned enough. I learned some in my first few years of practice. I did some hand-assisted surgery. I still do some hand-assisted surgery and use that as a tool, and have evolved. And the first time I did a robotic surgery was, the my first one. I'd never had training other than in cadaver models and things like that. So that was a challenge. The residents now are, every time I do a lap right, they're trying to get in to do that case because they don't want to do it robotically, because they know, even the ones who are interested in colorectal, they know they're going to go on to their fellowship and do a lot of robotic surgery. So it's the pendulum is swung again, that people are looking for the opportunities to do laparoscopic surgery. For me, it was learning new skills as a developing surgeon, and embracing the technology and trying to be a semi-early adopter. So it's, the technology is going so fast that we got to try to keep up with it.
Great, great. I don't see any hands up, so I want to thank you again for taking the time to participate. Great talk. We can stop the recording.